AHA, American Heart Association, CPR 2025 guidelines. We'll discuss about key changes and highlights, followed by the important points which are most useful for your INI-CET examination. Okay. We know that every 5 years, the guidelines keep updating, and this year in October 21st, the came, and the highest potential that you can expect at least 2 questions from this changes in the highlights. When they came in 2020, there are 2 questions straight within 15 days of the examination. So let's start with AHS-CPR 2025 key changes and highlights. Before that, we'll just quickly go through what are the 2020 changes so that it will be easier for us to continue this. So in 2020, the most important changes are, we know that in the chain of survival, the recovery component is added in both OHCA and IHCA, that is out of hospital cardiac arrest and in-hospital cardiac arrest. Now in 2025, that OHCA and IHCA have been removed and they made it a single chain for OHCA, IHCA in adults and pediatrics, which we'll discuss. But still, this recovery component which has been added is still relevant. Then in the recovery, multimodal rehabilitation assessment and treatment has been emphasized. And whenever a lay rescuer, when they are in a doubt whether they can start the CPR or compressions, they should go ahead. When they are in doubt whether they are able to feel the pulse or not, they should go ahead. We should not wait on that. Should not delay in starting CPR while checking for the carotid pulse. These things we discussed. And epinephrine. Emphasis on the use of epinephrine as soon as possible. Now, in the 2025 guidelines, they had mentioned time also in pediatrics also less than 3 minutes to do that, which we'll be discussing. Then audiovisual feedback. Emphasis on audiovisual feedback for effectiveness of CPR has been postulated. Then physiological monitoring, arterial blood pressure monitoring and ETCO2 monitoring, both they advised. And this is very important, which we keep discussing, debriefing. Debriefing has to be done for both technique effectiveness and psychological support. So not debriefing is after the completion of whether we resuscitation, whether it be successful or a failure, we have to sit, though all the people who are involved have to sit and discuss whether this technique is effective or like any changes has to be made in the future. And also for psychological support, if a question is asked, debriefing has to be done for psychological support as one of the statements, please don't mark it as wrong. It's a true statement because not everyone can take it so easily. Someone collapsing in front of them and trying to resuscitate and like some succumb. So that's the reason it's also very important. Then cardiac arrest in pregnancy, as we know, pregnant female are more prone to hypoxia. Oxygenation and airway are given importance. And ideal position for CPR was supine position with left uterine displacement. And perimortem cesarean delivery to be done within 5 minutes. In 2015, it was 4 minutes and which was increased to 5 minutes here. And fetal monitoring is not done during resuscitation. And if pregnant female is comatose, targeted temperature management is followed. We know here the targeted temperature management is 32 to 36 degrees centigrade for 24 hours. Now there is a slight change in this, which we'll be discussing in the 2025 guidelines. But fetal monitoring should be done when we keep the mother under TTM, targeted temperature management. In pediatrics 2020 updates, we met like breaths per minute 20 to 30. Cuffed endotracheal tube can be used. This was we remember breaths per minute 20 to 30 was the question which was asked in 2020 immediately after the guidelines came. We should not give cricoid pressure. And diastolic blood pressure increase in infants should be more than 20 mmHg and children more than 35 mmHg. That remains the same now. And for the detection of seizures, EEG is used to detect seizures, very, very important. And in children, non-convulsive status epilepticus is common, so we have to treat that. And recovery is very important. Neurological assessment and follow-up up to 1 year. These guidelines also remain the same, following up 1 year. Now, what are the changes? We are not discussing each and everything related to CPR. What are the changes and what are the questions that most potentially can be asked about? So, there are a total of 760 recommendations, and based on level A evidence, which is level A evidence is something where it is 100% proven and like where there are a lot of research and studies are there, only 11. But remember, in this 2025 guidelines, strong emphasis like how recovery was given, post-cardiac arrest recovery was given importance. Here, in addition to post-cardiac arrest recovery, equity and more importantly, ethics is given more importance here. Okay, across all the sections. And when you see this, earlier they used to have a separate guidelines for adult, pediatric, neonatal. Even now there are there, but there is a lot of integration between this adult, pediatric and neonatal guidelines. starting from even the systems chain of recovery, also chain of survival. Then when it comes to ethics, this is the first question, important question which you can be expecting. So there's a new standalone chapter built on 4 ethical principles, but I want you to remember these 4 points. What are the, all of the following are the ethical principles which has been postulated, except, so you can get a question of this. So these 4 things, please do remember the words: beneficence, non-maleficence, autonomy, justice. Beneficence is like, it's, we always try to do good for the patient. Non-maleficence is whenever, whatever the decision they're taking, it should not do no harm. And autonomy, we should respect the choice of the patient, whatever they opt for. If they say that do not resuscitate, we have to respect that. And justice, that fairness has to be there, like when we are giving the treatment. So please remember the 4 principles: beneficence, non-maleficence, autonomy, and justice. Please do remember. Okay. And they also focused on strong focus on eliminating inequalities in social determinants of health. This is like more about the principle similar to SDG, but sustainable development goals, but not exactly important here. And very important, please do remember here, shared decision making and documented advanced directives are encouraged. Now, considering in India, end of life care is improving, and even there are separate institutions being set up, and particularly when it comes to AIMS and PJ, they have been directed to start this end of life care guidelines which have been there. So in advanced directives like giving wills, and the patient writing what has to be done, what treatment can be given, and all these advanced directives are encouraged. So remember this word, advanced directives. Okay. Then institutional ethical committees recommended to resolve conflicts. So whenever they say, like, a few of the patient attendants say resuscitate and few say do not resuscitate, and like in those conditions, institutional ethics committees are recommended to resolve any conflicts when they are not able to, the treating physician is not able to decide. And this is important. This is slightly, it came as a surprise. Family presence during CPR is supported wherever is possible. So it is not, they mentioned, it's not mandatory, but wherever possible, they mentioned this line that family presence during CPR is supported wherever is possible. Okay, this is about the ethics component. Remember the 4 components and advanced directives. These are the 2 things which I want you to remember for sure. Then coming to systems of care. So when coming to chain of survival, there used to be OHCA, IHCA, the 6 components and all, which is separate for adult pediatrics, in-hospital cardiac arrest, OHCA, out-of-hospital cardiac arrest. Now they made all the things into these 6 components, where first is recognition and emergency activation, then high quality CPR, defibrillation, and then comes advanced resuscitation and post cardiac arrest care, recovery and survivorship. Earlier they stopped at recovery and they added one word, survivorship. So still there are 6 components: recovery and survivorship. Okay, so for all the 4 components, adult OHCA, adult IHCA, pediatrics OHCA, pediatrics IHCA, all combined into a single thing, single chain of survival. First, then coming to prevent in-hospital cardiac arrest. So where we will be seeing a surveillance component here, safety hurdles introduced to identify and protect any high-risk patient. You feel that when the patient is in a hospital, when you feel that the patient is more prone to get a cardiac arrest, we have to be super cautious, and safety hurdles have been introduced. And public access to naloxone added alongside automated external defibrillators. Now, how frequently you are seeing AEDs? Now you are seeing in the theaters, you are seeing in the airports, you are seeing in the railway stations. Similarly, they are asked to, the public access to naloxone also should be given. Then, when we're doing the telecommunicators, adults, if it is for adults, hands only CPR with the help of communication. If someone is supporting and like doing what to do during that time, in adults, hands only CPR can be practiced. But in children, because respiratory arrests are more common there, CPR with breaths has to be given still. Okay. And here, see here, debriefing also has been emphasized here. Here they mentioned, earlier in 2020 guidelines, they mentioned a debriefing has to be done for both technical effectiveness and psychological support. Here, they mentioned debriefing 2 times, not once, twice. Both immediate and delayed sessions recommended post CPR. Immediate, there's hot sessions, like immediately after that. Delayed is like once everything got settled down, probably in the suppose it happens in the morning, that day evening, or the next day, or by the end of the week. So consolidating. So debriefing has been given importance. Please do remember this. Then define team compositions for suppose a team of 6, like who has to be doing the air, taking the airway, who has to deal with the circulation, who has to deal doing the drugs, who has to take the history. So define team compositions for hospital and emergency medical services. CPR has been recommended, and they've been asked to write down every single day and to follow accordingly. Then whenever there is an out of hospital cardiac arrest, before transporting, try doing it like till the time arrives, like on-scene resuscitation is preferred. On-scene resuscitation is preferred before immediately shifting, unless until there is a level 3 ambulance to that. Then regionalized eCPR, extracorporeal CPR. This is again a buzzword, so please do remember extracorporeal CPR, very, very important, with clear patient selection criteria. This is, if they ask, the extracorporeal CPR can be given in a patient with a cardiac arrest. So yes, we can do that. And this is the image. This is the image, guys. So this is the ECMO circuit. This is a eCPR circuit where you can see the venous blood coming out and through the pump. In the pump, and finally it goes to the oxygenator. It gets oxygenated and again goes to the pump. This is ECMO. Okay, extracorporeal membrane oxygenation. Here, eCPR circuit will be there. This is called as extracorporeal CPR. So extracorporeal CPR, initiation of cardiopulmonary bypass during the resuscitation of patient in a cardiac arrest with the goal of supporting end organ perfusion while potentially reversible conditions are addressed. So this is very important. If it is asked as an image-based question, you should not miss out, guys. This is an eCPR or extracorporeal CPR. It has been, there are few patient selection criteria is given. So accordingly, we can do, not in everyone. Then structured post-resuscitation recovery programs. They didn't leave per se. There's a lot of things which has been given. So recovery has been given, has been emphasized a lot. This is very, very, very important. So this is about the major changes in the systems of care. Then coming to neonatal life support here. So they postulated deferred cord clamping for more than 60 seconds for both in terms or in preterms, both for more than 60 seconds. 60 seconds for better iron status and survival. This has been given in this guidelines. And hard milking is reasonable for any non-vigorous infants more than or equal to 35 weeks. When you are starting the initial ventilation, it has to be 20 to 30 centimeters of water of pressure at 30 to 60 breaths per minute. So please do remember, when in neonatal life support, in the initial ventilation, when the patient needs a ventilation, during that time, you can go to 30 to 60 breaths per minute. So please remember. Then in alternatives to intubation, the video laryngoscopy and laryngeal mask airway can be used. Video laryngoscopy images I have shown you in the class, and also LMS can be used. Like LMS were mentioned in the last 2020 guidelines also. Now they added video laryngoscopy also, because anyhow, like when you're doing it, it's easier for you under vision if you do this intubation with the video laryngoscopy. Then pulse oximeter placement as soon as possible. Like, we have told, if not the regular pulse oximeter, you can give the reflectance pulse oximeter where you can attach to the forehead, and as soon as possible. And the oxygen, like in preterm, start with 30 to 100% slowly, because we also have to think about ROP. Then chest compressions, lower third of sternum. This is very important. They emphasized on lower third of sternum. Earlier, they say like even you can do at the level of nipple, but they're emphasizing on the lower third of sternum. And change the compressor every 2 to 5 minutes. Okay, this is about neonatal life support. Then pediatric life support, the CPR pauses should be less than 10 seconds. And compression technique, this is very important. So earlier, this is like heel of one hand, like you can do it with the heel of one hand, or 2 thumbs encircling hands at the level of nipple. And here, 2-finger technique has been completely removed. In the 2020 guidelines, they said that 2-thumb encircling hands technique is preferred, but now 2-finger technique has been completely removed. So this is another important thing. So please do remember this. Then this is again a potential question which you can expect in severe foreign body airway obstruction, FBAO. So what happens? What do you do in children and infants? In children, it has to be 5 back blows and 5 abdominal thrusts. Alternate, 1 back blow, 1 abdominal thrust, 1 back blow, 1 abdominal thrust. So please do remember this. Whereas in infants, it is 5 back blows and 5 chest thrusts alternate. So this, if you see, when compared with adults, here it is again 5 back blows plus 5 abdominal thrusts, alternate cycles. So in children and adults, it is 5 back blow, abdominal thrust, back blow, abdominal thrust. So this you do it 5 times. Whereas in infants, the back blow and chest thrust. Please remember this, they categorically mentioned, so it's very important. Then coming to adult basic life support. So I showed you the images of head tilt and chin lift in the class. So there's acceptable for ventilation. If not, like jaw thrust, you can use the jaw thrust. If jaw thrust fails in the trauma, you can use head tilt and chin lift. Then ventilation, 1 breath every 6 seconds. This is visible chest rise. This remains the same. Compression ventilation ratio 30:2 is maintained. That is also fine. And mechanical CPR, use only if manual CPR is unsafe. What is mechanical CPR is, there is nowadays the CPR automatic devices is there. You have to just attach that machine and you have to set the rate 30:2. You have to set like how much 120 compressions per minute. It keeps doing it. So that is a mechanical CPR. That is not a routine. Like though there are many of the hospitals which started using it, but mechanical CPR is not a routine. Use only if manual CPR unsafe. This they clearly mentioned because of the rise in use of mechanical CPR. Use only if manual CPR is unsafe, then go for mechanical CPR. It's not a routine. Then, while using defibrillation pads, so this is one thing they mentioned in females when they are doing, particularly in conditions of open out of hospital cardiac arrest and all, instead of complete removal of the bra, just adjust and so that it improves equity in women. That is what it has been added. Then in obese patients, the standard CPR technique applies. It's not about no head-up positions and all, nothing. You can do the standard CPR technique. And then we discussed severe foreign body airway obstruction, 5 back blows and 5 abdominal thrusts in alternate cycles, similar to the children, what we use. Then coming to PALS, pediatric advanced life support. Epinephrine, adrenaline should be used as early as possible for non-shockable rhythms, less than 3 minutes. They mentioned the time here. So less than 3 minutes, start using the epinephrine. And end-tidal CO2 should be more than 20 mmHg target. But earlier we discussed about like failure to achieve ETCO2 more than 20 mm of Hg, even after 20 minutes of effective CPR is one of the criteria for termination. This is one of the major termination criteria, but it's not the sole criteria. Okay. And then diastolic blood pressure targets earlier from 20 to 35. There's a slight change to 25 and 30, 25 mm of Hg in infants and 30 mm Hg in the children. That is one thing. And if it is SVT, supraventricular tachycardia, which is unresponsive to adenosine, you can use IV procainamide, amiodarone, or sotalol. These 3 options are there. Okay. And again, this is again a potential question. Post cardiac arrest in the recovery phase, how much blood pressure has to be maintained? The options can be like you have to keep the same as the mean blood pressure, like which is of percentile of age, increased BP blood pressure or decreased pressure. You have to at least maintain BP at the greater than 10th percentile for the age, because that helps in increased perfusion and recovery. Then EEG, we already discussed in 2020 guidelines. Again, EEG has to be done up to 72 hours for neurological prognosis. Don't rely on just the gag reflex alone or cough reflex where they're doing it. So you can follow up to 72 hours. And rehabilitation, comprehensive follow-up should be done for 1 year post-arrest. This remains the same as like 2020 guidelines. Then when it comes to adult advanced life support, ACLS, the first shock more than or equal to 200 joules of biphasic for atrial fibrillation or flutter cardioversion. We can do for the cardioversion for AF or flutter, we can give up to 200 joules. Then vector change and double sequential defibrillation, benefit is uncertain. There's no guidelines, so unlikely the question can be asked on this. So then, even in 2015, they postulated this like IV preferred over intraosseous route for drug delivery. So this remains the same. We view IV. And epinephrine after failed defibrillation in shockable rhythms. As we all know, shock CPR adrenaline, shock CPR amiodarone or lignocaine. Shock CPR adrenaline, shock CPR amiodarone or lignocaine in shockable rhythms. In non-shockable rhythms, it is CPR adrenaline. CPR adrenaline will keep continuing this. Then universal termination of resuscitation rule endorsed for all the emergency management systems. And this is one thing I want you to remember. Temporary transvenous pacing is also reasonable for refractory unstable tachycardia. In refractory unstable tachycardia, you can give temporary transvenous pacing. You can go ahead. Okay. Then there are few changes in the post-cardiac arrest care. We all discussed the mean arterial pressure has to be maintained more than 65 mm of Hg to avoid hypotension. And we also discussed like to keep more than 10% in the top 10th percentile during the recovery phase. And temperature control. So it should be earlier, they say like for targeted temperature management, 32 to 36, right? Here after TTM, once the patient is recovering post cardiac arrest care, it should be 32 to 37.5 degrees for more than 36 hours post return of spontaneous circulation. So once the patient achieves the return of spontaneous circulation, we have to keep a patient between 32 to 37.5 degrees for more than 36 hours. Then after return of spontaneous circulation, we can do head to pelvis CT, echocardiography, and focus. Focus is point of care ultrasound to check the how all those things can be done. And for neurological recovery, we can even do the MRIs. Okay. And this is going to be the potentially expecting question here. What is the new biomarker for neuroprognostication? Very, very, very important. And there's guidelines for this. Please do remember this neurofilament light chain, NFL. This is a new biomarker for neuroprognostication. How after post-cardiac arrest, how patient is recovering. What is his prognosis? Like how they will fare in the future. So this neuroprognostication, neurofilament light chain, please remember, potentially expecting a question on this. Neurofilament light chain. Okay. And before discharge, structured psychological assessment for survivors and families, because it's not so easy for them. Like we can say easily, okay, you survived, it's good, like it's so we have to give a psychological assessment, like structured assessment. We have to counsel the patient, that is a survivor, and also the families before discharge. These are the changes in the 2025 guidelines, which are very important for us. So to quickly consolidate, you tell me, like I may not remember all the points, but tell me like 5 to 10 points which I'll remember. Then remember the 4 points about, I'll just quickly revise the 4 points about the 4 ethical principles: beneficence, non-maleficence, autonomy, justice. Okay. And importance has been given to advanced directives. Second point, family presence during CPR supported wherever is possible. Chain of survival, OHCA, IHCA, adult pediatrics all combined into single thing, and they made it into 6 components. Again, the 6 components are there. In the 6th component, just not the recovery, they added the word survivorship. Then debriefing can be done twice, both immediate hot and delayed cold sessions recommended post-CPR, but both technical effectiveness and psychological. And eCPR, extracorporeal CPR, can be done as based on the patient's electrical criteria as much as possible. Then video laryngoscopy and laryngeal mask airway approved alternatives to intubation. Video laryngoscopy is also mentioned. And then initial ventilation, we can go up to 30 to 60 breaths per minute also. Then delayed cord clamping more than 60 seconds for both in terms and pre-terms. Then pediatric life support, 2-finger technique has been removed. Then when it comes to severe foreign body airway obstruction, infants, 5 back blows and 5 chest thrusts alternate, whereas in children and adults, 5 back blows plus 5 abdominal thrusts. So please remember this. So you may get question potentially based on the infants and ask like whether the chest thrust or abdominal thrust, or which all of the following are true, except in those way they can ask about that. Then mechanical CPR is not a routine, use only if manual CPR is unsafe. Then post in SVT, unresponsive to adenosine, you can use IV procainamide, amiodarone, or sotalol. And post arrest, maintain blood pressure more than 10th percentile of age, and epinephrine should be given within less than 3 minutes for non-shockable rhythms. And EEG up to 72 hours we have to for neurological prognosis. And rehabilitation, as mentioned, We have to do it for 1 year post cardiac arrest. Then temporary transvenous spacing we can go in case of refractory unstable bradycardia. And very important, temperature control post return of spontaneous circulation 30 to 37.5 degrees, 37.5 degrees centigrade for more than 36 hours. We can do that. And the new biomarker for neuroprognostication, very, very, very important, neurofilament light chain NFL. Okay, this is about the 2025 changes. And again, the rest of the things you have to remember, like what are the 5H and 5T, hypoxia, hypovolemia, hypothermia, then H plus ion, acidosis, hypo or hyperkalemia, then 5T, toxins, cardiac tamponade, coronary thrombosis, pulmonary thrombosis, all these things has to be remembered. Okay, and 5H and 5T are the reversible cause of cardiac arrest, which we should be remembering this. So this is about 2 questions, anticipating 2 questions at least. If not, in worst scenario also, we'll get 1 question for sure in this. In the last 25 minutes, you got 1 question for sure, and potentially 2 questions are expected from these guys. Okay. Now, let's quickly discuss about what are the other potential things. We'll quickly revise in the next 25-30 minutes. Entire anesthesia important points will quickly in a go, we'll discuss about. Okay. So coming to ASA physical status classification, there are 6 grades, 1, 2, 3, 4, 5, 6. 1 is a normal healthy person, important are non-smoker, non-alcoholic examples. 2 is a patient with say I'll share this PDF, so no need to, don't just listen and see. Visual and auditory memory only should work now. Try to recollect. 2 is a patient with mild systemic disease, current smoker, social alcoholic, pregnancy with BMI 30 to 40. 3 is a patient with severe systemic disease. Examples are alcohol dependence, BMI more than 40, CKD patient on regular dialysis, any patient who has history of CAD, transient ischemic attack, CVA more than 3 months, and pacemaker. 4 is a patient with severe systemic disease with a constant threat to life. Please do remember this. And these examples are AKI, CKD patient on irregular dialysis, history of CAD, CVA, transient ischemic attack less than 3 months, and patient with sepsis and DIC, disseminated intravascular coagulation. And 5 is a moribund patient who is not expected to survive without surgery. Examples are multi-organ dysfunction syndrome, thoracic or abdominal aortic aneurysm rupture, intracranial bleed with mass effect, and ischemic bowel with significant cardiac history, all the things. Then 6 is a declared brain dead patient whose organs are being removed for organ donation purposes. And anywhere if you use the word E, letter E, that indicates emergency. Then METS, metabolic equivalent of task score. 1 METS is the rate of energy or oxygen consumption at rest, that is 3.5 ml per kg per minute. METS 5, please remember, METS 5 is climbing 1 flight of stairs, that is dancing and bicycling. If they ask about like what is the calculate the METS of a person, you know, like 1 METS is 3.5 ml per kg per minute. It's a 60 kilos person of 5 METS. So 60 into 5 into 3.5, that's how you can calculate. Then important image-based question, modified Mallampati grading. Grade 1, you can see grade 1 and 2 are easy intubation, 3 and 4 are difficult intubation. In 1 and 2, you can see all the components. Uvula, entire uvula, you can see that pillars, fauces, entire uvula, soft palate and hard palate. Whereas when it comes to 2, you can see the pillar, you can see the fauces, but not the pillars. So fauces, uvula without the tip, and soft palate and hard palate. Whereas when it's 3, you don't see the pillars and fauces, you see only uvula, that is only the base of uvula, soft palate and hard palate. In 4, you don't see anything except the hard palate. Then what are the drugs that has to be continued and stopped for surgery? Aspirin less than 75 mg, you can continue. Aspirin more than 75 mg, stop 3 days before surgery. Clopidogrel 5 to 7 days. Warfarin 3 to 5 days. The 4, if it is unfractionated heparin, 6 hours. Low molecular heparin, if you are using for prophylactic dose, 12 hours. And for therapeutic dose, 24 hours. Then remember what are the fasting guidelines for breast milk? 4 hours, very important. When it is a formula milk, it is 6 hours. Then when it comes to children, if 2 hours, and for the recent guidelines, it is 1 hour. So if option is 1 hour is there, you can go ahead. If not, for this for clear fluids. For clear fluids, 1 hour and 2 hours. If 1 hour option is there, please go ahead with this. Other than that, if not, then 2 hours. Then it comes to colors of the cylinder and important components of the cylinders. Remember, all the gases are stored in a gaseous form except nitrous oxide, carbon dioxide, and cyclopropane stored in liquid form. The pin index of air is 1.5, oxygen is 2.5, nitrous oxide 3.5, carbon dioxide both 1.6 and 2.6, cyclopropane 3.6, NOx 7, and helium is 2.4. And air and oxygen, the pressure is around 2000, and nitrous oxide and carbon dioxide around 760 psi. The colors of the cylinder: air, it is gray body with white shoulder; oxygen, black body with white shoulder; nitrous oxide is blue in color; carbon dioxide is gray; cyclopropane is orange in color; NOx is a blue body with white shoulder; and helium is brown in color. Then the last year question in INI-CET: what is the circuit of choice for controlled ventilation in children? Answer is F. So remember, circuit of choice for spontaneous ventilation in adults is A, Magil circuit. In children, it is Jackson-Rees circuit. For controlled ventilation in adults, D, Bain circuit, and in children, F, Jackson-Rees.